Good morning, everyone. My name is Derrius Anderson, a resident at University of Chicago, research fellow at Endeavor Health, formerly North Shore University Health System. Really appreciate the opportunity to share my research with you all today here at SAGES. And so we'll be talking about Barrett's esophagus after laparoscopic fundoplication. The senior author has the following disclosures. All other authors have no other disclosures. And I hope that was 7 seconds. Alrighty. So the ASPECT trial showed us that high-dose PPIs, BID, and aspirin are chemopreventative against the development or progression of Barrett's esophagus to high-grade dysplasia or esophageal adenocarcinoma. And multiple studies have shown similar outcomes for laparoscopic anti-reflux surgery, additionally even showing resolution or regression of patients' Barrett's esophagus after anti-reflux surgery. But there's limited data that really speaks to when or if we can discontinue PPIs after laparoscopic anti-reflux surgery. And so additionally, there really isn't any data that comments on if we can consider spacing surveillance endoscopy in these patients with Barrett's after anti-reflux surgery. And so our study aims to investigate if and when medical therapy can safely be discontinued after anti-reflux surgery, and also if it's safe to space endoscopic surveillance of Barrett's esophagus in the appropriate patient. And so we queried our prospectively maintained single-center gastroesophageal database for this retrospective review. And we looked at patients between 2010 and 2022 who had a history of Barrett's esophagus who underwent toupee or Nissen fundoplication. And so they gave us 146 patients with Barrett's esophagus. We removed those with high-grade and low-grade dysplasia in addition to malignancy. That left us with 81 patients with uncomplicated Barrett's esophagus. 36 underwent no surgical intervention, 23 Nissen fundoplications, and 22 toupee fundoplications. And so these are the results of that total of 45 patients that we reviewed in this series. 12 patients at our center had resolution of their Barrett's esophagus, 18 had no progression, and 15 were lost to follow-up. And I think it's important to point out here that no patient within our series had progression of their Barrett's esophagus to high-grade dysplasia, low-grade dysplasia, or esophageal adenocarcinoma. And between the two groups, and overall all patients, there really is no difference in their demographics and characteristics. One thing to point out, though, is the duration of symptoms. In the no progression group, the median years of symptoms was 8 years compared to 3 in the resolution group. And so laparoscopic anti-reflux surgery, the goal is to recreate the anti-reflux barrier. And at our institution, routinely, 1 year post-operatively, we will do a Bravo exam to test the durability of our repair. And I think that's especially important in patients with the history of Barrett's esophagus to ensure that the gastric juices and bilious juices are being protected against perpetuating the metaplastic esophageal adenocarcinoma pathway. And so these are our post-operative Bravo results. In the resolution group of the 12 total patients, 4 underwent post-operative Bravo testing, which were all negative. In the no progression group, 7 underwent Bravo testing with 6 negative results. The 1 positive result was placed back on the PPI. And finally, in the loss of follow-up group, 1 out of 2 patients had a negative Bravo study. And so overall, 12 out of 14 patients after anti-reflux surgery had a negative Bravo exam, which is roughly about 85%, which is fairly in line with other published data in regards to the durability of our repair. And so this here is a Kaplan-Meier analysis. And what we're actually looking at is the resolution of Barrett's esophagus over time after anti-reflux surgery. And in this particular Kaplan-Meier analysis, all patients that are examined are off of PPIs. And so at 5 years, nearly 50% of patients who are off of PPIs had resolution of their Barrett's esophagus. And so the limitations of our study, small sample size, only 45 patients are included in this review, single institution as well. And unfortunately, 33% of our patients were lost to follow-up, and who knows how that would have impacted our data that we've seen. And so in conclusion, if patients with Barrett's esophagus have a negative pH study after laparoscopic anti-reflux surgery, we recommend stopping PPIs. Furthermore, within 5 years of undergoing successful laparoscopic anti-reflux surgery, nearly 50% of patients are off of PPIs. Who are off of PPIs will likely have resolution of their Barrett's esophagus. And so seeing that resolution or lack of progression of Barrett's esophagus, we recommend reconsidering the frequency of surveillance. Thank you, and I can take any questions.
Thank you very much. It's very hard for us to see the patients because the lights are in our eyes, but please announce yourself, the microphone over here, and feel free to ask your question.
Hi, Kyle Perry from Ohio State. This is a great presentation. It's an important topic. A question about your post-op testing. How long after surgery were you doing that? And if it's early post-op, and you're stopping the patient's PPIs, how are you going to assess or decide if you ever need to put them back on it or repeat their pH testing? Is that all based on symptoms, changes in surveillance? How would you?
Definitely. I appreciate those questions. So as far as our postoperative Bravo exams, they're usually done at 1 year post-op at minimum. Some patients are coming back even later than that, just in regards to how tough it is to get them in for follow-up. And then secondly, in regards to thinking about, if we need to repeat pH studies and the endoscopic surveillance, the answer to that question that we've thought about is, in considering spacing of surveillance, I think that might be an opportune time to also proceed with repeat pH studies. And the reason why we state that is that some studies have shown that although patients have a lack of symptoms, that doesn't mean that they're not experiencing any reflux. And so I do think it's important to still keep an eye on if those patients are having silent reflux, because those are the patients, I think, in Barrett's esophagus that you actually really are concerned about, just because they really don't have any symptoms.
Another question?
So we remember excellent talk, great topic, like you said.
Thank you.
Any idea about the length of the Barrett's preoperatively as compared to the resolution, on resolution?
So in our group, we actually had no difference. And I really, because I went through each individual chart and looked at short segment, and we defined that at 3 centimeters. And so there really wasn't any different in our series, but I know that there is data out there that exists that shows that patients with a shorter segment of Barrett's esophagus are more likely to have resolution.
I can ask you a question.
Yes, sir.
I have no argument with your data and your recommendations, but my question really is whether your data and the number that you have in your series are sufficient to make these recommendations. I mean, do you feel this now could be a recommendation that goes out and guides therapy, or if not, what are the next steps?
I honestly think that in regards to, like, if I were an attending and practicing now, I think it would be something I would push for at my center, but also I think the not lucky, but the thing that we can do is also study it as well as we're doing it. And, tell these patients that your risk of transformation to high-grade dysplasia or esophageal adenocarcinoma is X. And we think that you actually have a pretty low risk of transition. And so to save you, the risk of PPIs and to save you the risk of procedures, we'll ideally follow you every 5 years, repeat endoscopy, repeat Bravo. And I think that that's things that we can then further publish on to strengthen our data.
Thank you.
Awesome. Thank you.
Thank you very much.
And we welcome to the podium the group from Bern with a presentation entitled Persistent Dysphagia After Magnetic Sphincter Augmentation, Shifting Paradigm with One-Stop Repair, Laparoscopic Removal, and Conversion to Reflux Stop Procedure by Dr. Foregut.